أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. Today, these sort of figures and pictures, they really make us sad. I am in practice for the last almost 40 years now, and for 25 years almost I am dealing with pediatric glaucoma. This is one of the most devastating diseases which one come across. It's not only that in this disease the visual systems of the child is affected, but his whole life is changed. Not only his life, but his family, because of so many visits to the doctors, many surgeries, many medicines, and still we may end up without a visual seeing eye. We know the childhood glaucoma is basically an intraocular pressure related damage. In adult glaucoma, there are so many other mechanisms, but in childhood glaucoma, it's primarily the intraocular pressure. Although the intraocular pressure is the main mechanism for damage, but for assessment, probably it has much less value for assessment, diagnosis, and prognosis, as to check intraocular pressure in children, pediatric patients, is very difficult, and is affected by so many factors which may alter the results of the measurements. Other signs of glaucoma in infants and young children, which are ocular enlargement, half strides, and cup to disc ratio, become much more important in this regard. This is one of the child with bilateral congenital glaucoma, and one eye is more advanced. This is the typical half stripe, the horizontals breaks in the Descemet's membrane. We classify childhood glaucoma mainly into primary childhood glaucoma and secondary childhood glaucoma. Primary childhood glaucoma, again, depending upon the ophthalmos present, primary congenital glaucoma, which usually occurs before 3 years of age, when there is scleral distension, and juvenile glaucoma after that age, when there is no scleral distension. Secondary childhood glaucomas, they may be associated with non-acquired ocular anomalies, with non-acquired systemic diseases or syndromes, and they may be associated with acquired conditions like uveitis, trauma, retinal detachment. Glaucoma following cataract surgery is another important class of, because pediatric cataract surgery, it has got a high rate of developing later on glaucoma, and we know that in first few months of life it may be as high as 50% of cataract surgeries. This is how we classify the childhood glaucoma. Number one, we take the definitions for this childhood glaucoma. The intraocular pressure is more than 21 millimeter of mercury, optic nerve cupping, half striate corneal edema, increased corneal diameters, myopic shift or increased axial length, and visual field defects. And any two or more than of above will constitute a childhood glaucoma. If only one of them is present, then we put the patient into glaucoma suspect. Glaucoma, if it is occurs or detected only after cataract surgery, then probably it is due to post-cataract surgery glaucoma. And it may be all congenital, idiopathic cataracts or others. It may be associated sometime with glaucoma already, but might be somebody has missed the diagnosis. And again, if there is no cataract surgery and there is congenital anomalies present, then they are glaucoma associated with non-ocular anomalies or systemic anomalies. And if systemic anomaly is not present, then this is the ocular anomalies, glaucoma with ocular anomalies. And history of trauma, steroid, uveitis, tumors, etc., they will constitute glaucoma associated with acquired conditions. And if there is ophthalmos present, all these are not present, but ophthalmos, then it's a primary congenital glaucoma, and as we said, if there is no ophthalmos, then there is juvenile open angle glaucoma. Primary congenital glaucoma is an isolated angular anomalies. There sometimes may be present congenital anomalies of the iris. It's meet glaucoma definition with ocular enlargement, and the subcategories are based on the age of onset. So any one which we call congenital or neonatal glaucoma, a newborn onset which is less than 1 month of age. Infantile glaucoma is less than 2 years of age, and late onset or more than 2 years of age. As the time of diagnosis or appearance of the disease is in older children, the prognosis for treatment that is increased. Cases with normal intraocular and optic disc, but typical signs of primary congenital glaucoma, that may be a ophthalmos or half striae, that are not progressive, may be classified as spontaneously arrested primary congenital glaucoma. These are the angle anomalies associated, and this is how we approach to the evaluation of a glaucoma. Again, because many of these children will be smaller and not non-cooperative, they will need an examination under anesthesia. And we have to perform that, and that might have to be performed many times, not only once, because sometimes the diagnosis be suspected. And we say, don't label a child as glaucoma unless you are sure, because labeling a child as glaucoma is really something very painful. So, in fact, establishing a diagnosis is very much important, and not only establishing a diagnosis, but a prompt diagnosis of childhood glaucoma, and appropriate prompt treatment can minimize the degree of visual impairment. Glaucoma in children is characterized by presence of elevated intraocular pressure and characteristic optic disc-cupping. In addition to these features, glaucoma in infancy is associated with ocular enlargement, that's called ophthalmos. IOP measurement, as we know in infancy and early childhood glaucoma, can be influenced by many factors. So it's often unreliable and been used in diagnosis and management. So again, although it's a pressure-related damage, but the primary risk factor is difficult to measure. Increasing corneal diameter is one of the hallmark of all forms of glaucoma in infancy and early childhood. And in fact, any enlarged diameter of cornea must be suspected. A child should not be labeled as having glaucoma or subjected to surgical treatment unless one is reasonably sure of the diagnosis and has excluded other conditions that may mimic glaucoma. These are differential diagnoses of glaucoma. We know that it may be glaucoma, and there are corneal or ocular enlargement due to other reasons like megalocornea, congenital myopia, connective tissue disorders, and these mutations. Corneal haziness, again, they may be caused by obstructive trauma. Corneal dystrophies, metabolic disorders like mucopolysaccharidosis, infection, and Peters anomalies. Sometimes mucopolysaccharidosis. It's again difficult. There may be a glaucoma present, and one has to be very much cautious because you cannot see the fundus, and there is corneal haziness present. Other cause of epiphora, because again congenital glaucoma may present with epiphora, nasolacrimal duct obstruction, conjunctivitis, or some form of keratitis. And then congenital optic nerve anomalies will again have to be differentiated from the actual form of glaucomatous cupping. Another thing again is not only diagnosis but the progression, because progression, if we determine the progression, that will tell us whether our treatment is successful or not. There are few signs we can look at that rapid changes in refractive status and axial length determination are helpful in both diagnosing the disease and determining response to treatment while the sclera remains vulnerable to the effects of elevated IOP. So it is advisable that you should always check the axial length in infants with corneal diameters and intraocular pressure. Axial length outside normal limits is strongly suggestive of glaucoma, and continued enlargement of axial length beyond the normal range suggests inadequately treated glaucoma, and progressive myopia is additional evidence of glaucoma progression. These are the normal and the suspected diameters. A newborn will have a corneal diameter less than 10.5 millimeter, while anything 11 or above will be suspected. And so at 1 year, anything above 12 millimeter, and at 2 years, anything about 12.5 millimeters should be suspected of glaucoma. And so are the axial length, these should be measured, and anything about 20 millimeter at term newborn will be of high suspicion. These are the normograms. The red line is the average curve for the axial length measured in millimeter against the age and months. When coming to the management of glaucoma, the management of an infant or child with glaucoma is really challenging. We have been treating both the adults, although glaucoma treating in an adult is also something of a real challenge. But when it comes to the children, then it's the real challenge. It is chronic disease affecting infants and young children with normal life expectancies. So we have to look at the blindness years the person might come across, because if the child of 2 years get blind, he will remain blind for another 70 years. Childhood glaucoma are heterogeneous in their causation as well as in their response to different glaucoma medication. So in fact, as the causative factors are so many, so are the response to the medication and treatment, because it is very unreliable to predict what will be going on. And when using the medicine in glaucoma, the systemic pharmacokinetics for glaucoma medications are different in children than in adults. It's not only that the children are small adults, they are totally different in response to the medication. The medical management is something of temporary in primary congenital glaucoma. While surgery is the mainstay of glaucoma treatment in infants and young children, medical therapy has an important role to play in the management of childhood glaucoma. Medication alone rarely shows sustained efficacy as primary treatment for glaucoma in infants and young children, especially in primary congenital glaucoma. Medical therapy is frequently needed as temporary IOP lowering treatment before surgery or as an adjunct therapy for partially successful surgical procedures in childhood glaucoma. Some of the childhood glaucoma that may be related to uveitis glaucoma after cataract surgery or trauma and other like, they might benefit from medical therapy a lot. Potentially serious or fatal systemic adverse reactions which are rarely seen in adults may occur in young children after exposure to glaucoma medication. And again, children are very much more vulnerable to adverse effects of medication as they may be unable to verbalize symptoms and communicate it to the parents or the physician. And the parents may not be readily able to recognize them. So the side effects of the drug, which in an adult maybe the damage is prevented by diagnosing it early, may not be easily diagnosed in children and may cause a very serious effect. Again, brimonidine should not be used in infants or small children weighing less than 40 pounds, as it may cause bradycardia, hypotension, hypothermia, hypotonia, apnea, especially if they are used with beta blockers. Another more important thing is the compliance and adherence issues, which are much more greater in children and much more complex due to their dependence on caregivers or parents and possibly lack of cooperation in the administration of treatment. Again, although intraocular pressure measurement is difficult, but we have to suggest some target intraocular pressure which we have to follow for glaucoma progression. So we should be able to control intraocular pressure adequately. Pediatric glaucoma surgery is challenging because of the difference in anatomy from the adult. Not only that the anatomy is different from the adults, but again the behavior of the tissues of a child's eye is totally different from the adult. There may be a lot of inflammatory response or healing response. The variety of causes of the disease are different, and so maybe the surgical treatment may have to be modified every time. And again, there is a lot of difficulties with post-operative management. Children are not very much cooperative, not very easily to be seen with the microscope, and every time they might have to be taken to the anesthesia, which will pose other risks for the children's health. And the lack of cooperation again affects the degree of monitoring and post-op follow-up, which can compromise surgical results. So you may not be able to detect early the complications which are going to happen or the healing which are going to happen because of the lack of the cooperation. A very important point, because any surgery, the first surgery is always the best time, and especially in children. In children, the first surgery performed should be perfect. Otherwise, the subsequent surgeries become very difficult. And again, as earlier I said, the surgery for glaucoma is difficult and is much more difficult for pediatric patients. So, and again, the number of patients are less. So every specialist may not be able to have good enough experience. So glaucoma surgery should preferably be performed by a trained surgeon in center where there is sufficient volume to ensure surgical experience and skill and safe anesthesia. Glaucoma surgery in children is more challenging than in adults, with a higher failure and complication rate than in the adults. Angle surgery, goniotomy and trabeculotomy, is the procedure of choice for primary congenital glaucoma, with the exact choice dictated by corneal clarity and the surgeon's experience and preferences. Trabeculectomy, when performed by experienced childhood glaucoma surgeon, can be associated with good outcomes in appropriate cases. Combined trabeculectomy is argued to be more successful than either procedure performed alone. It is the primary procedure of choice in populations who are thought to be at greater risk of failure because of more severe or advanced presentations, like in our societies.
Sir, two more.
Acha, theek. Glaucoma drainage devices again are another choice for surgical treatment. Cyclophotocoagulation with diode laser has limited long-term success and then requires retreatment and the continuation of medication. Other glaucoma procedures educating children for the treatment of glaucoma have not been widely adopted, either because of the technical challenges in ophthalmic eyes or because they are not yet to be proven efficacies or safety in children, like deep sclerectomy or viscocanalostomies. So this is, we always say that the goniotomy or trabeculotomy, the angle surgery should be the first choice. Again, in those cases which you are not, the eye is too big or the cornea is not clear, the patient has reported late, then combined trabeculotomy plus trabeculectomy will be the alternate choice. And so on, you go to other surgeries depending on success. Another important thing is the follow-up. It is important to remember that even with long-term well-controlled IOP, relapse can occur at any stage. Following successful goniotomy, approximately 2 to 3% of eyes each year and 20% over a 30 years period of time were found to relapse. Furthermore, sight-threatening complications may occur at any time, even after years of stability. This emphasizes the need for lifelong follow-up. And we can see that even a large amount of glaucoma capping can be reversed with successful treatment. One more important thing is the management of amblyopia. We may be able to control the intraocular pressure with treatment, but we may forget to recover the visual acuity which is lost due to amblyopia. So in summary, corneal diameter is very much important. Gonioscopy again has got a crucial making the correct diagnosis. Optic disc appearance should be recorded. Compliance and adherence are greater in more complex children, and glaucoma surgery should be performed by a trained surgeon, and although it's a very challenging disease. Thank you very much for your attention.
You like to use more if the goniotomy or trabeculotomy phase was still in phase of going for further surgery, and in between that time, which of the drugs you like to get?
In fact, safety of the drugs, we know that in pediatrics, no drug is very much safe. But the prostaglandin analog and the carbonic anhydrase inhibitors, they have got the highest safety margin. So these should be the first choice.
नहीं आप मैं अनाउंस करने लगी हूँ आप ही करें
बिस्मिल्लाहिर्रहमानिर्रहीम। साथ साथ कुछ बातचीत भी करेंगे ना।
सर आपके बाद एक और प्रेजेंटेशन है।
वही एक्सपेक्टेड था, ये हादसा हो के रहना था।
नहीं वो सनद बैठी हुई है। आप वो इन्हें शेरों के ज़्यादा बेशक जरूरत है।
अब सिर्फ शेर ही होने हैं।
लेकिन ऐसे होने चाहिए जो समझ आ जाए।
जलते हुए परवानों पे हैराना हुआ कर, यूं मेरी मोहब्बत से परेशान हुआ कर।
माशाल्लाह।
डोंट बी सरप्राइज्ड while seeing burning moths. वो तो है, इसको तो कोई कमांड लगाओ, ये मान नहीं रहा। कंट्रोल वो डिस्प्ले क्या आ रहा है? हाँ वो तो लगाया है जो अल्लाह मंजूर। ये देखो इससे आएगा, इससे आएगा स्केल्ड डिफ़ॉल्ट।
आपने कौन सी पोर्ट ली है?
HDMI
आगे हो गया डिस्प्ले आ गया से प्रेजेंटेशन शो
डिस्प्ले नहीं है तो सिर्फ बैकग्राउंड आ रहा है।
कनेक्ट हो गई
HDMI दे दें क्योंकि आपने मेरे ख्याल वो
यहाँ से फिर एक
दूसरी
सेकंड
वाली पोर्ट
सर किसी पोर्ट लगी हुई
है।
सी पोर्ट है सर
सी टू HDMI दे दें। कौन सी?
सर आपको वीडियोस भी कोई कॉपी करके सही
कॉपी नहीं करना, मुझे बगैर करना कर
आपने
लेते हैं।
HDMI ली है, ठीक है।
तो हमारा टॉपिक है ऑप्टिमाइजिंग पीडियाट्रिक कैटरेक्ट सर्जरी। So we all agree that pediatric cataract surgery is different from adult cataract surgery. So what are the main differences? One is that the eye is too difficult to tackle preoperatively and too difficult to handle intraoperatively because of increased flexidity. And the third is that postoperatively it is too reactive. So in preoperative planning, this becomes very important to plan it well. And for that, generally you need EUA and other things. In this particular presentation, we are going to try to optimize pediatric cataract surgery to attain good results. First thing you need to decide is whether cataract is significant, and that depends upon the location of the cataract, whether it's involving the visual axis or the opacity is away from the visual axis. And the size of the opacity, generally it is agreed that it is around 4 millimeters in size. And then the timing, when do we need to intervene? In uniocular cataract and in binocular cataract. In binocular cataract, the age to intervene is 6 to 8 weeks, because if you don't intervene by 2 months, nystagmus will develop and that will be there for life. In uniocular cataract, the age of intervention is 4 weeks, because you know how to correct amblyopia, 1 week per year of age, and the same thing applies as embryogenic age as well. 1 week per year of the age is the period needed to occlude a pediatric eye to get amblyopic as well. So if you don't correct uniocular cataract by 4 weeks of time, the child will get densely amblyopic and maybe squinting as well. Then axial length, while we are biometric issues, at birth it's around 17 millimeters and adult eye is around 22 to 23 millimeters. So 6 millimeter of size, almost 16 to 18 diopters of IOL power will change by adult life from birth. Similarly, the cornea will also grow and change its power from pediatric eye to adult eye. And the total dioptric power changes from around 34 diopters to 18 to 19 diopters in adult eye. That's why while you are planning the IOL, you have to be careful. And what is to be preferred then? That you want myopia, emetropia or hyperopia? The real critical age, very interesting thing about axial length changes and corneal changes. The maximum change occurs in first year followed by second year. For example, from 17, about 4 to 5 millimeters the eye will gain by 2 years of age. And only 1 millimeter growth is here from 2 to 20 years of age. So, if you are treating a child at 2 years of age, then you probably don't need to much worry about the residual error. You can just go for emetropia. But if the child you are doing it by 2 months of age, that means it is going to grow by 4 to 5 millimeters in next 2 years. So that's where the undercorrection comes important. The second thing which is not mentioned in textbooks generally, the more the high power you choose for intraocular lens, the lens will become bulky. And sometimes it is difficult to inject. So keep that in mind as well. So what I do is, if I have to operate by 1 to 2 months of age, I find the maximum power, that is around 30 to 31, 32 diopters. And Acris of multipiece is the length which I prefer. Because in pediatric surgeries, you are not always able to hit you are not able to always place the IOL in the bag. So that's the IOL power and undercorrection. And then as you have undercorrected, then within first month or within 6 weeks after surgery, the EUA will be mandatory, so that you are able to prescribe the residual refractive error. But if the child goes myopic, there is nothing to worry, because the myopes tend not to get amblyopics. Hyperopia is more amblyogenic. So if at all you have to choose for your child between amblyop, आजा यार किथे चले सोने तेन अखियां उड़ीकदियां दिल वाजा मारदा आजा ला दे जो भी लगता है. तो we were at IOL power calculation. So myopia is preferred. Even minus 12 diopter child is able to read it here by 8 centimeters. 10 diopter child is able to read at 10 centimeters. Now you have planned and you are ready to operate. General anesthesia is needed. The smaller eyes are there to handle. Anterior capsule is more elastic and difficult to rex. Scleral rigidity is low, so the vitreous will bulge. That's why the capsule tends to rip. Increased vitreous pressure, unstable anterior chamber, and then there is a risk of high PCO pacification. Almost 100% rate is there. That's why we recommend that you perform posterior capsular rexes or posterior capsulotomy as well, especially below 2 years of age. What's my criteria? In which child I will go for posterior rexes or anterior vitrectomy? Any child who is not able to sit at slit lamp, is not cooperative, I will do this. If a child is able to get a regular biometry and a regular slit lamp examination, that means this child may be able to get the post-op YAG as well. Then I just irrigation aspiration and implant and leave it. And moreover, by the time the child is 6 to 8 years of age, there will be decreased reaction and the PC will be less thick. Now in CN, where to place it? 12 o'clock. We don't prefer the temporal incisions because of the again decreased scleral rigidity and poor wound sealing. We want it underlaid. So in pediatric eyes, 12 o'clock is the position. And the incision size, same, which you use for IUL, maybe 3 plus minus 3 millimeters. And don't leave the wound just hydrated. Always stitch it because you will not be able to see it properly in postoperative period. So all 3 ports, I use 3 ports, 1 central and 2 on the side, and I apply 1 stitch on all 3 ports. You can use 9-0 Vicryl or 10-0 Vicryl. If it's not available, simply use 10-0 nylon, and while you perform first TUA, remove the sutures. But don't leave it unsutured. That's the consensus. IUL, ideal IUL is Akrusov multi-piece or a single piece IUL, or both should be arranged. If you are able to implant IQ or any aspheric lens square edged into the bag, go for it. But due to any reason, if you are not able to implant your lens into the bag, the square edged lenses, all of them are contraindicated for sulcus placement. So if only one lens is to be arranged Akrusov multi-piece with round edges. And if you enjoy the luxury of having 2 lenses as standby, then you can arrange for an aspheric or a spheric square edged lens with Akrusov multi-piece as a standby lens. Surgical technique, in whole of your surgical procedure, keep the chamber well formed. Never operate a pediatric eye under shallow AC. And in the end, I inject about 400 micrograms of dexamethasone intravitreally. I don't prefer injection canocord. And the consensus is there about IUL usage around 2 years of age. But beyond 2 years of age, there is controversy. But my own preference is that I implant IUL at any given age. I don't operate pediatric cataract without IUL implantation. So the complications in pediatric cataract surgery and good results can be attained by adopting proper technique and taking proper care preoperatively, modifying your technique intraoperatively, and be vigilant postoperatively. Thank you very much. तो हम स्लाइड्स के मोहताज छोड़ेंगे. वो पूरा टेबल है, वो मैं आपको व्हाट्सएप कर देता हूँ अमेरिकन एकेडमी का. He is asking that what are the recommendations for power, underpowering the IUL. Generally, I have told you, but there is a table by American Academy of Ophthalmology which I follow. But that's not necessarily to be followed. I have already discussed, by 2 years of age, aim for emetropia. Before that, you can aim for about +2 to +6 diopters of hyperopia in first 2 years. By 2 years, the child will be emetrope again. So it's not a big science, just you need to be vigilant that I have to correct whatever residual I have left in first TUA, and then you have to follow it up every 6 months and go for the incremental correction. The second question was
size of eyeball.
Size of eyeball. Oh, if it is a microphthalmia, then the situation is different. Otherwise, in regular eyes, which is about 16-17 millimeters, but other features are normal, and there is 10 to 11 wide to wide diameter. That's why we prefer this 12.5 millimeter single piece lens.
My question, axial length is if it is 19 or below the 19, there is
lens remains the same, accuracy of multi-piece.
There is contraindication of lens.
No, it's not contraindication. There is no contraindication.
Everything causes the glaucoma.
It will not. It will not, if it is properly placed in the bag, it will not cause the glaucoma. Only you just keep in mind that you have to avoid a bulky lens. You may more undercorrect it if the eye is too small. The bigger the power, the more the undercorrection.
Adding to his statement, actually at age 6 and before, the lens implantation is usually contraindicated for the simple reason you are saying that the patient develops a glaucoma.
I would very humbly differ from the chairman of the session with.
और glaucoma नहीं हुआ.
Size of the is important size. If 19 and below the 19, we can't employ. Eye की size जो है ना
नहीं हुआ. For that reason, the age when it is less than 6 months, the size of the eyeball is around 18, 17 and a half or maximum of 18.5. That's the reason for which usually it is avoided. आप उसको कर रहे हैं, आपका experience है, लेकिन generally it is said that lens should not be implanted in this.
There are two things. One is personality. You may have very good case one time and you may end up with a very bad case another time. It's the evidence base. What evidence says and what interpretation says of experts. Anything you do personally against the recommendation. But recommendations is that at least
और वो असल में मुझे चेयरमैन साहब के रुख मुबारक से 6 years अदा हो गया था, तो मैं डिफर करने लगा था. 6 months is the age. There is a lot of controversy about IOL implantation before 6 months of age, but increasingly the tendency is to implant, though we choose the IOL more carefully. For example, this Hoya multi-piece IOL or Hoya aspheric IOL is very thin. Similarly, the Alcon IOLs are very thin, but most of the hydrophobic IOLs with low refractive index are very thick. That's where you need to be careful, that choose the thinnest IOL available. But it is a relative contraindication. The more challenge, the more the controversy. When I started pediatric presentations about 15-20 years ago, the age was 6 years. Then it became 4 years. Then now the real consensus is at 2 years of age. Below 2 years, it is still controversial. And 6 months, as respected Professor Shafiq has told, now increasingly the pediatric surgeons are agreeing on 6 months of age. But the number of surgeons going for IOL implantation at any given age is growing. Though you choose the IOL more carefully and you undercorrect more, if the eye is shorter than 19 millimeters, choose the smallest dia lens and choose whichever lens is the thinnest in its thickness and choose a less power.
Thank you so much, Professor Zal Mazri. Our next speaker is the moderator of the session, Dr. Sana Nadeem, who is working in Fauji Foundation Hospital, Rawalpindi. I request her to come to the dais and speak on the topic of anterior segment OCT in pediatric ocular pathology. Come on, sir.
Assalamualaikum. I'm Dr. Sana Nadeem and today I'm going to present anterior segment OCT in pediatric ocular pathology. I'm working as an assistant professor in the Department of Ophthalmology, Foundation University, Islamabad. Optical coherence tomography is a non-invasive imaging modality which utilizes infrared light reflected by the ocular structures to create intricate micron-resolution three-dimensional images. Anterior segment OCT, a rapidly emerging technology, is immensely useful in diagnosis and monitoring of pediatric eye disease and may be used as a measuring tool for corneal thickness, anterior and posterior chamber depths, AC diameter, chamber angle configuration, and even iris and lens thicknesses. The rationale of our study is to investigate the anterior segment OCT in pediatric eyes presenting with any pathology of the anterior segment, to image the diseases and to describe the features visualized by this emerging technique. A total of 78 cooperative children between the ages of 2 to 17 years presenting to us with anterior segment disorders were included in this study. Non-cooperative children and with severe intellectual disabilities were excluded. This 15-month study was carried out between August 2020 till December 2021 in Eye Department, Fauci Foundation Hospital, Rawalpindi. Best corrected visual acuity and refraction was done together with anterior and posterior segment examination and ultrasonography as needed. The Optopole Revo 80 high resolution spectral domain OCT was used, which is a head and chin mounted device and non-contact with no need for anesthesia. An imaging adapter was used in all cases with an internal fixation target. The eye was aligned and good quality images were captured. A total of 115 eyes of 44 male and 34 female children presenting over a 15-month period were included. The majority clinical diagnoses were cataract, followed by corneal disease, glaucoma of various types, trauma, iris flattening, conjunctival tumors, among others. Associated systemic diseases were found in 21% of our cases. So these are tables depicting the corneal pathologies, anterior chamber pathologies, and the various cataract types presenting to us. Any lens opacification was found in 37.4% of our cases, along with other pathologies of the angle, iris, conjunctival, scleral, and even vitreous cells could be visualized. Anterior segment OCT is immensely useful in corneal and ocular surface diseases. Increased corneal reflectivity was observed in 29.6% of the eyes, with mainly from corneal tears or corneal scars. This is a corneal scar. This is a self-sealing corneal tear. Corneal opacification due to various pathologies, band keratopathy, corneal thickness and corneal edema were visualized in 24.3% of the cases, and this is a case of acute eye drops. Corneal stromal thinning observed in 27%, mainly with scars and keratoconus. This is a patient with a conjunctival flap in a case of ocular mucous membrane pemphigoid. In anterior chamber and angle evaluation, it is also very important. Narrowing of the angle was observed in 13% of the eyes, mostly with trauma, tumors, and also ectopia lentis. Detailed anterior chamber angle evaluation and that of the Schlem's canal was done in patients with juvenile open-angle glaucoma, and in one case we observed abnormal iris tissue in the angle which was not discernible on gonioscopy. The Schlem's canal was visible in all cases of JOAG and secondary steroid-induced glaucoma. One case of neovascular glaucoma secondary to retinoblastoma had a narrow angle due to anterior displacement of the iris lens diaphragm. Conjunctival nevi was observed to be heterogeneous, diffuse or dome-shaped masses with conjunctival cysts and posterior shadowing. Conjunctival limbal dermoids were heterogeneous masses also associated with posterior shadowing. A lot of lens morphologies were observed. This is a lamellar cataract, posterior subcapsular, anterior capsular fibrosis, posterior capsular opacification with large L-Schnitt pearls, anterior polar cataract, and total cataract, which was found in the majority, along with posterior capsular fragility or absence, posterior lenticonus. Primary aphakia was seen in one case of PHPV, and nasal lens subluxations were also diagnosed. In iris disorders, we observed iris flattening in JOAG, secondary glaucoma and trauma. Posterior synecdoche, iridodialysis could be observed, and persistent pupillary membrane over the lens. A detailed evaluation of traumatized eyes is possible by means of anterior segment OCT to delineate the extent of the corneal or scleral tears, uveitis, and cataracts including lens rupture. This is a flower-shaped lens rupture imaged by the full scan of the anterior segment. Corneal tears were classified into lamellar, total thickness, self-sealing, and total thickness with iris prolapse. Scleral tears were similarly classified into partial and full thickness. Iridodialysis and iris tears were observed, and traumatic lens subluxation and cataract was also observed. In scleritis, we observed full thickness scleral thickening along with subepiscleral fluid pockets and heterogeneous hyporeflectivity, and it is also useful in assessing the depths of the scleral tears and also in cases of occult trauma. In surgical planning and evaluation, planning of corneoscleral repairs can be done, cataract surgery, postoperative evaluation, intraocular lens position, and trabeculectomy, bleb, and fistula evaluation. This is a patient with primary aphakia. OCT has found a leading position in research after its introduction in the 1990s. Anterior segment OCT, since its advent in 1994, has subsequently been utilized to provide an optical biopsy. Its applications are manifold, including pachymetry, ocular surface disease, conjunctival corneoscleral pathology, anterior segment tumors, pediatric glaucoma, biometry, cataract uveitis, anterior segment degenesis, and evaluation of surgical procedures. Strengths of our study is that it's the largest study on a pediatric cohort and also the first of its kind in our country. Limitations are that we failed to include infants, smaller children, and non-cooperative ones, for which handheld OCT would be more useful. Our spectral domain OCT at 840 nanometers has provided detailed anterior segment imaging. However, for deeper angle structures like the trabecular meshwork and the ciliary body, the sweat source OCT may be more useful with 1310 nanometers. To conclude, we would say that our study reflects that anterior segment OCT is a useful non-contact technique without sedation for detailed anatomic and pathologic assessment, imaging, diagnosis, and monitoring of pediatric eye disorders. I thank you for your time. This research is available as a preprint on medRxiv. Any questions?
Thank you so much. If there are any questions?
Good to for the anterior segment assessment by the
And
how to classify the angle by OCT?
Sir, there are different classifications which have been proposed by different people, but I haven't classified that accordingly, but we can just, according to the Schaeffer's classification, we can also use that.
OCT.
Yes, on OCT, because the angle can be measured with the angle measuring tool of the OCT in degrees. Yes, then it will be shallow. Yes,
So
and
this is
10,
what
yes.
he's asking.
And
Roughly how do we
yes,
grade?
sir, because there is an angle measuring tool of the OCT,
Yes.
and we place it at the angle and then on the iris and the cornea, and that gives us the angle in degrees. And in the majority of the open angle, it is even as enlarged as 70 degrees even. So in the Pakistani population and in juvenile open angle glaucoma, mostly it is more than 40 degrees as in the Schaeffer classification, which says 40 degrees is open. So it's even 70 or 80 degrees in our pediatric population, but 20 or less and even occludable in cases of anterior segment disorders and also, Seineke and others. So, but for other papers, they have, I think, classified according to OCT as well, different classifications.
And we use it for PTK as well to plan it.
Yes.
Phototherapy.
Yes, for refractive surgery as well. It can also be used for topographic assessment as well, but our OCT currently does not have that attachment, and also for biometry as well.
You can measure the thickness of the cornea
GG.
with the
Yes.
anterior segment OCT.
Yes.
And accordingly you can plan the phototherapy keratectomy, how much to remove.
Actually, I use the OCT anterior segment a lot, especially in my training. So actually, there is like a specific piece that we put it with a swim source OCT, then it will take the angle exactly. Then we just make two lines that you can measure the angle. The most like best evidence about the OCT, we will look at if it's narrow or if it's closed or if it's open. This is the main point. And you can measure it. If it's thin, so we call it just narrow angle. It's by OCT source, especially by Doppler. This is how we measure it. Yeah.
And other type of OCT we can also use.
Yes, but that's what we use in short.
Okay, the time of the session is already over. I'm thankful to all the speakers.